The benzodiazepine drugs are one class of central nervous system depressants that have served us pretty well for quite a long time. For many years, they were the most commonly prescribed drugs for sleep, but no longer. The benzodiazepines are not the oldest hypnotics. That distinction goes to the barbiturates, which I'll talk about in another video. But they were used for a long time. They were kind of the cornerstone of therapy for insomnia until they were replaced as preferred drugs by non-benzodiazepines, which I will also talk about in another video. Benzodiazepines can be used as anxiolytics, and we learned about them in the anxiolytic lesson. But they also can be used as sedatives and were used for a long time for sleep. Compared to the barbiturates, they looked good. But compared to the newer non-benzodiazepines, they have greater risks. That one of the biggest things is their probability of causing physical dependence. In other words, a potential for abuse. The benzodiazepines are divided into long, intermediate, and short-acting drugs, and you have a table in your textbook that describes that. We are familiar with diazepam, one of the long-acting barbiturates. We know diazepam, and I'm going to switch to that slide quickly, because of its use in treating status epilepticus. It's less likely to be used as an anxiolytic these days. It's a long-acting benzodiazepine, and so that makes it a little less desirable. Intermediate acting benzodiazepines, we also know as anxiolytics, lorazepam, alprazolam, for example. And we know that lorazepam can be used for status epilepticus as well. Short-acting drugs include midazolam or Versed, and we learned about the Versed benzodiazepine in another lesson because it is used for conscious sedation. It has a rapid onset, it's rapidly metabolized, it's a short-acting drug, and so it works really well for moderate or conscious sedation. You can see that I crossed out the names of 3 drugs. Those are actually non-benzodiazepines that I'll talk about in another video. I left them here in this slide, and primarily because it reflects the table in your textbook, but they're not benzodiazepines, and so I've crossed them out for your reference. So how do the benzodiazepines actually work? How do they bring about their sedative and hypnotic activities? They work with GABA, a neurotransmitter that's an inhibitory neurotransmitter. The natural activity of GABA is to prevent overstimulation of neurons in the central nervous system. And there are evidently these benzodiazepines chemically or molecularly are a good fit for those GABA receptors, and so they mimic the activity of GABA, maybe even strengthen it, I think I would say. And so they reduce CNS stimulation of the brain. They were an improvement over the older barbiturates because they didn't have a negative effect on REM sleep as much as the barbiturates did. So when the benzos came along, they were an improvement. They were also an improvement over the barbiturates, as you'll see in the barbiturate video, because the barbiturates were known to be inducers of metabolism of other drugs, and the benzos don't do that. So they calm us, and they can be used for anxiety. As we learned, they can also help to bring about skeletal muscle relaxation. So the list of indications is really long, but sleep induction is not so much an indication anymore. We know them as sedatives, we know them as anxiolytics, we know them as useful for treating status epilepticus. They can be great drugs for helping patients who are withdrawing from alcohol to avoid the central nervous system stimulation and the kind of even delirium activities that people who are acutely withdrawing from alcohol can experience. They have a place in balanced anesthesia, but also a place in moderate or conscious sedation. The adverse effects of benzodiazepines compared to those of the barbiturates, the drugs they replaced, seem pretty mild. Drowsiness and dizziness, and so that means that they can really increase the risk of falls if they're being taken by older adults, and sometimes people experience kind of a hangover, a daytime sleepiness effect. And of course that's a problem if you've got to get up and go to work. You need to, if you're needing help to manage insomnia, you need help falling asleep and staying asleep, but you need to be able to wake up in the morning. And so the longer acting benzodiazepines are more likely to cause a hangover effect. People can take too much of this, and then you get oversleepy. You can even go into a coma. It drops down your reflexes. It tends not to cause respiratory depression, in other words, stop breathing, unless you would overdose with benzodiazepines and other central nervous system depressants. And so for someone who's overdosed with benzodiazepines, we need to just make sure that they are supported until the drug is metabolized and they begin to wake up again. There is an antidote, a particular drug, flumazenil, which competitively antagonizes the benzodiazepine at the GABA receptors. I don't expect you to memorize that, but it is nice to know when there's a specific antidote for a drug that can be used for an overdose. There are a number of drugs that benzodiazepines will interact with. The biggest one to note is the CNS depressants, an additive effect, dangerous respiratory depression if somebody would accidentally take too much of this. And then there are drug interactions where they can affect metabolism negatively. I already referenced diazepam as an example of a long-acting benzodiazepine and midazolam as an example of a short-acting benzodiazepine that can be used for moderate sedation.